Thank you, Dr. Chauhan. Quickly, I would request Dr. Viveka to do his presentation. Everybody knows him. He is the director of Unmatched Cardiac Cath Lab and a very senior and eloquent cardiologist and a very, very knowledgeable person. And he has been at the forefront of multiple trials with most of the new medications which are being introduced in India. The molecule for discussion today being Inclisiran, of which he has been a primary investigator for the last 2 or 3 years. And I would hand over the mic to him to carry his presentation forward.
Well, so good evening, friends. Another Wednesday, another series, and today we are going to discuss about the molecules which are revolutionary. I think I'll be speaking on the lipid lowering in patients who have got atherosclerotic cardiovascular disease, especially the uncontrolled dyslipidemia, who are failing to meet the current targets. And then Dr. Bhavna would be speaking on another revolutionary molecule which has been, gone off patent, is Empagliflozin. So both of them are really very close to my heart, I think, because they are the ones which are decreasing the mortality in Indian population. And globally, if you look at under larger perspective. So if you look at the residual risk, we have been trying with can we have the lights off at this thing if you want to see it more clearly? So if you look at the patients with or a high risk of atherosclerotic cardiovascular disease, there are a lot of things which can be done to decrease the atherosclerotic cardiovascular risk. One is, of course, controlling the blood sugar, that is controlling the HbA1c, controlling the lipids, controlling the triglycerides, especially in the Indian population, and of course controlling the lipoprotein. So there are a lot of things which are, we say, is contributing to the residual risk of cardiovascular disease. So real world data on achieving the recommended LDL level. So we always say that the slogan of controlling the LDL level is lower is the better. And when we were students, it started from target of 130 of LDL, and now it has come down to less than 50, so that is the aggressiveness of this. But if you look at the reality of the matter, is that the molecule which was there till now with us was statin, and it was not really able to control. We were happy that we are giving the molecule to our patients, the LDL is going down, but we are not really concerned about the target. So stiff target has been set, and if you look at the cumulative effect of LDL cholesterol, so when the plaque builds, it is the combination of how much amount of LDL cholesterol is exposed to how many number of years. So I was having a discussion with Dr. Bhavna Atri also, that familial hypercholesterolemia is one thing where the cholesterol starts rising at a very young age. So you need to lower the cholesterol in them at a very young age. And the other problem in familial hypercholesterolemia is that the patients will not have, the LDL cholesterol does not come in target very easy with the conventional drugs. So there also you need to be really aggressive. So number of years and the level of LDL cholesterol is the contributing factor. So obviously we need to hit them hard, and we need to hit them early so that the number of years of exposure to that becomes significantly less. So if you look at the cardiovascular risk classification, and this is a strict target by Indian lipid guidelines. So there are two guidelines, one the Cardiology Society of India guidelines, and then the Lipid Association of India guidelines. And there you can see that they are targeting that the secondary prevention, we need to bring it down below 55 milligram per deciliter. But if you look at the Lipid Association of India guidelines, that asks that we should bring it below 40. So it means that we need to be really aggressive, and we have, other than statin, quite a few molecules like ezetimibe and bempedoic, but they're not really, making most of the people bringing them in target. So the things which we have apart from statin, bempedoic acid, ezetimibe, and then PCSK9 came a little early than the inclisiran. So inclisiran and PCSK9 are the injectable ones which have really turned the tide against the LDL. So if you look at the non-statin LDL lowering agent, we have ezetimibe, bempedoic acid, and then the PCSK9 inhibitors and the inclisiran. So the advantage of inclisiran is that the duration is long. So once in 6 months subcutaneous has to be given, and whereas the PCSK9 inhibitor has to be given every 2 weeks. So that is why really it is much more easier in Gen Z population. So current people who are into multinational companies and all, they say that it's like you get one shot and forget for next 6 months. So that is the beauty of inclisiran, where every 6 months you need to get the injection, whereas with the PCSK9 inhibitor you need to get it every 2 weeks. So does it worth it? Because if you see like Sindhu from Lipin said that the cost of the therapy is around 1,50,000. They give discounts. Then it will come down to 92,000, and they have got multiple collateral benefits with this. But definitely it is worth it, because not only it decreases if you look at it with ezetimibe, the decrease in LDL cholesterol is not huge, but when you see the PCSK9 inhibitor and the inclisiran, the drop in the LDL level is significantly high, and most of our patients, more than 80%, will reach the target. So effect of bempedoic acid and all is not that great. So even if you combine bempedoic acid with 40 milligram rosuvastatin or 80 milligram of atorvastatin, that does not really bring them to the target. Even the data which came from clear outcome, CVOT outcome with bempedoic acid, it had some statistically significant benefit on decreasing the cardiovascular risk. So that is why it became a frontline drug. But definitely in patients who are not really reaching the target, it's not doing the service. And there are a lot of patients who are statin intolerant, or the patients with familial hypercholesterolemia, where it is not really effective. So what we need to do, we need to look for the molecule which serves the purpose and brings the LDL level within the target. So inclisiran is the first LDL cholesterol lowering siRNA therapy, which is liver specific mechanism of action, and what it does is that it binds with the MI receptor and would bring down the LDL cholesterol level, and it has got a sustained effect. So you don't need to take it like PCSK9 inhibitor every 2 weeks. After first dose, the second dose is after 3 months, and then every 6 months you need to take it. And now it is an off-level thing which I am going to tell you, is that in the Indian population, in my experience, we have seen that the effect lasts for more than 9 months. So we have seen that the LDL cholesterol goes down 10. In fact, one of my colleagues from Odisha, he reported 2 cases where LDL was not detectable after 2 doses of inclisiran. It means that it went so low that, so obviously it will also lead to plaque regression. So this is the only therapy. So we were part of the, as Dr. Chauhan said, Victoria plaque study, where we looked at the CT coronary angiogram, moderate degree of plaque, and then at 2 years of therapy, we saw that the plaque regression was significant. So obviously, it is one of the molecules which can be thought of at decreasing the plaque level. So if you look at the Orient 10 data, the effectiveness and sustained reduction of LDL cholesterol compared to the placebo in patients with associated cardiovascular disease, there is 52% effective reduction, and it is sustained, so almost 54% reduction. And this graph clearly shows that it's not a something where there will be a rebound phenomena. It is sustained, and we have got our Indian data which is showing that sustained effect of lowering the LDL is significantly longer. Instead of 6 months, it might be 9 months. So Orient 9 data also says that the effective sustained reduction in the cholesterol is significantly longer. So inclisiran reduce the level of other atherogenic lipids. So if you see the lipoprotein little a, that has been found to be a very big and strong risk factor, because if the person's lipoprotein little a, which is a genetically determined marker, where if it is in combination with high LDL, it causes more atherogenicity. So it makes LDL cholesterol more atherogenic. So if you decrease the lipoprotein little a, which does not go down by statins or any other oral therapy, only by PCSK9 inhibitor, but with the inclisiran also, almost 30% reduction in lipoprotein little a is there, and there is slight improvement in SDL level. Triglyceride also goes down by almost 15-20%. So it means that this is something, and ApoB, which is again a surrogate marker of coronary artery disease, that also goes down by more than 40%. It means that the other things which, other risk factor which does not go down with statin would go down with this. So, and that too without any major side effects. So it means that the adverse event rates are as good as placebo. It means that in tolerating this molecule is pretty easy, and most of the patients, I haven't had any patient who did not have any, who said that he had any problems. So there is no side effect as far as our experience goes. Just the local pain as a subcutaneous injection and all, and we have data right from Orient trials, all 6, 8 and 10, all of them did show that the patient did really well. So if you look at the inclisiran safety and efficacy in various ethnic population also, and large number of Asian population also included in Orient 18, there also it showed that it's fairly well tolerated, and patient level analysis of phase 3 trials suggested benefit in cardiovascular outcomes. So there are few molecules which decrease the LDL cholesterol but would not translate into the decreasing the MACE rate, that is major adverse cardiovascular event over 18 months. But this is a molecule which decreases the risk of myocardial infarction and also the stroke. It means that it is a molecule which not only decreases the LDL but overall adverse outcome, and the hard endpoints like MI and stroke comes down. As I was talking, we were part of the Victorian trial also, CVOT outcome trials, and there also in Victoria plaque prevent and plaque reduction trial, there we saw but the CT coronary angiogram that quite a few patients had significant reduction in plaque severity also. The patient who had 60-70% blockages, that also came down significantly. It means that the intensity of lowering the LDL has a power of decreasing the plaque burden also. So inclisiran in patients with myocardial infarction also, it provided effective and consistent LDL reduction and lowering the effect, and the repeat myocardial infarction. So you must remember that any patient who had one myocardial infarction, they are almost 3-fold higher risk of having second coronary event. And if you decrease the LDL cholesterol level by inclisiran, because not only you are decreasing the LDL, increasing the SDL, but also decreasing lipoprotein little a and triglyceride, so that is why the risk becomes significantly lesser. In Victoria, inclisiran first, the Victoria initiate randomized trial also looked at that, and this trial also showed that if you look at the co-primary endpoint, percentage change in LDL cholesterol was quite significant, almost more than 53% reduction in that was there. So if you look at the almost 330 days, almost 1 year data came, and that showed that there was a safety also. So it's not only efficacious, but because there are a lot of good potent drugs, but they would have significant side effects. But this is a drug where the side effect is minimal. So if you want to manage the dyslipidemia and acute coronary syndrome, and it has now come in guidelines as well, that if you are not achieving the targets, that is LDL cholesterol level less than 50 milligram per deciliter, then we can go for injectable ones, and inclisiran is much more, more preferred drug in this situation than PCSK9 inhibitor because of its cost effectiveness over 6 months and also ease of use and slightly better potency as well. So I think on that note, I will conclude my talk and would ask you to note down your questions, and we meet you again, as promised by Dr. Chauhan. And I will request Dr. Bhavna to not make you feel my absence. Dr. Bhavna, over to you now.
Sir, just one very easy question.
Very easy question. There is no question which is easy in this forum.
Like we say that prevention of coronary artery, not MI, if by regular exercise, diet reduction, so can this molecule be added in that list? Prevention of MI, particularly second MI?
Yes, I think second MI, so if you look at the secondary prevention of mitral infarctions, even if the patient had interventions, either CABG or had a stent, then the second event reduction is significant. The number needed to treat is only 23. It means that it's a very, very robust molecule. In fact, we have seen, so the USP of this drug is reversal of coronary artery disease. So because you can decrease the LDL to rock bottom and probably you can, regress the plaque also. Okay, thank you very much.
Thank you, sir.
Which means that most of the interventional work will also go down.
No, we are not greedy. Thank you. Okay, thank you.
So thank you, Dr. Viveka. So I'll now quickly go over to the next talk, and Dr. Bhavna, she is well known to the forum. She is an endocrinologist with the Sarvodaya Hospital, and she will be dwelling on Empagliflozin, which has recently gone off patent as a prototype SGLT2 inhibitor. SGLT2 inhibitors, as we all know, that have marked a paradigm shift in the treatment of diabetology the world over. Apart from its cardiorenal metabolic effects, we are looking at huge effects cutting across the spectrum, and MS, LD, neuroprotective actions, musculoskeletal actions, and even things going far beyond the originally thought mechanisms of action and benefits. So over to Dr. Bhavna to take the scene forward.
Thank you, sir. So, good evening, everyone. So, as sir said that the patent has been off for Empagliflozin and the molecule is now much cheaper. So, I know the last portion of this discussion would be which is the better one, Empa versus Dapa. Usually this has been happening in the last 2 months when the patent has released. So, I would just say that majority of the effects of the SGLT2 inhibitor are the class effects. So, and when we compare these trials, we should not forget about how we need to compare a trial. There are a lot of confounding factors and the baseline parameters which differ in comparing these values. But yes, SGLT2 inhibitor, wonderful molecule for diabetic, in fact non-diabetic patients as well, in terms of reducing the incidence of cardiovascular diseases, heart failure, hospitalization, mortality, and the renal parameters, deterioration in diabetic patients. So talking about Empagliflozin in current T2DM management perspective of endocrinologists and all the people who manage diabetes, I think most of us. So from 2022 ICMR data, what we know that majority of the Indian population, I think this is true with many studies, many longitudinal studies that have come up, that almost 70% of Indian population is not achieving the target of less than 7%, which has to be there. So this is the huge burden of uncontrolled diabetes that we carry, and so is the huge burden of complications that we have. And we look at other parameters, that the LDL level less than 100 milligram per DL, that is also not there with more than 50% of our population. So both the blood pressure control, blood glucose control and lipid control, that is not good despite having such good molecules available to us. Talking about the cardiovascular risk in newly detected type 2 diabetic patients, even the people, the diabetic people who are newly detected, they also carry this huge cardiovascular risk burden. We all know that a type 2 diabetic patient, even at the time of diagnosis, must be having a number of issues, must be having a subclinical atherosclerotic disease, maybe having neuropathy, nephropathy. So we need to screen for all the complications in the beginning as well. So even the newly detected diabetic patient carries a great cardiovascular risk factors. So from this study, newly detected Indian type 2 diabetic patients are at high atherosclerotic cardiovascular disease, and therefore we need to screen each and every diabetic patient for the possible CVD, CAD and other heart and kidney related disorders even at the beginning. Talking about the data, ASCVD affect 1 in 3 patients with diabetes worldwide, and CAD is the major CVD burden in diabetic patient, affecting 1 in 6 type 2 diabetic patient, 2 in 3 patient with congestive heart failure and 1 in 3 patient with CKD. So ASCVD, diabetes and kidney dysfunction goes hand in hand, because the reason behind the onset and progression of these diseases is same, which is obesity, insulin resistance and other inflammatory parameters. So considering such a close association between the two conditions, the pharmacotherapy and the doctor, they have realized that all the drugs should pass on to the CVOT trials, and while going through the CVOT trial they found out new molecules which are not only safe but they protect one from the cardiovascular and the renal dysfunction, and hence the ADA guidelines they drastically changed in the last few years. Earlier it used to be metformin, sulfonylurea, gliptin and so on. Now they say if someone has got ASCVD or multiple ASCVD risk factor or heart failure or CKD, do consider adding SGLT2 inhibitor or GLP-RA1. So these drugs have now become an important part of management of type 2 diabetes, and I think almost any one patient, even a newly detected type 2 diabetic patient, would classify into the need of these molecules. So, and second, obesity. Most of the prior diabetic molecules, they carry the chances of weight gain, carries the chances of hypoglycemia, which is not there with this molecule. So they are safe, they are in fact protective towards the risk factors, they don't cause the weight gain, in fact some extent there is a weight loss, and then the chances of hypoglycemia alone with this molecule is not there. We have a robust evidence for empagliflozin, starting with the EMPA-REG outcome, which was conducted in type 2 diabetic patients which carry the atherosclerotic disease or multiple atherosclerotic cardiovascular factors. They found out that the 3-point Cmes was drastically reduced with this molecule, and then came up the Emperor trial with preserved and reduced ejection fraction, where the trial was conducted irrespective of diabetic status. So means good number of patients were non-diabetic. So hence now this molecule has become a molecule for cardiologists as well. It's a treatment for heart failure. We know that we don't need to always look for the echo whether the ejection fraction is, because good number of diabetic patients have got preserved ejection fraction heart failure. They may be symptomatic and we do the echo, it's normal. So we have to do proBNP and other tests to find out, and that thing need to be managed because that carries a high risk factor for mortality. So SGLT2 inhibitor is a wonderful molecule for reducing the chances of heart failure in such patients, that has been proved beautifully by the Emperor trial, both in the preserved and the reduced ejection fraction. All the primary composite endpoint, whether it was cardiovascular mortality, 3-point Cmes, or renal death because of the renal dysfunction, was significantly reduced with this molecule versus placebo, and the trial results were equally good for whether the patient has diabetic or had diabetic. Then lastly they came up with the EMPA kidney trial, which was solely done to see the results for the kidney patients. Here they had people with EGFR of more than 20, and they divided into 2 groups. One more than 45 EGFR, another group less than 45 EGFR, and the composite outcome was the chances of patient going into end-stage kidney dysfunction, EGFR declining to less than 10, or more than 50% reduction in the EGFR, or requiring dialysis, or death due to kidney dysfunction. This composite outcome was statistically reduced in patients who were given empagliflozin versus placebo, irrespective of diabetic status. People are now giving this molecule in other nephropathies like IgA nephropathy. There are trials that have shown beautiful results. So not only the diabetic nephropathy, but other tubulointerstitial disorder, this molecule is being tried off now by the nephrologist as well. Because this molecule has got 2 effects. One is by controlling the blood glucose, and other direct effects which are happening at the level of tissue. It is reducing the inflammation at the level of cells. It is bringing down the blood pressure. It is improving the cholesterol levels. So therefore, there is the reduction in the atherosclerotic burden that is happening. As I said in the beginning of these slides, it's not good to compare the EMPA, CANA, DAPA, depending upon these trial. I think it's majority of it is a class effect. Some studies may say, some people may agree that they say good results with empagliflozin versus the dapagliflozin, but I would say it's a class effect. Yes, comparing empagliflozin 15 and 10, I would say the glycemic effect is better with 25 milligram versus the 10 milligram. So we can, for the diabetic patients, we should give 25 milligram, and for the non-diabetic, we can start with the 10 milligram. So, in terms of the quality of life improved with this molecule, we know that cardiovascular diseases is a main cause of mortality for the diabetic patient. An addition of empagliflozin increases their life years by reducing such burden. So, analysis based on EMPA-REG outcome data demonstrate the potential impact of reduction in mortality with empagliflozin in people with type 2 diabetes and established ASCVD, and the 4.5 years mean difference in the life that the people had gained with use of empagliflozin versus placebo, which was significant. In patients with diabetes and atherosclerotic CVD, again from the EMPA-REG outcome, they could find out that empagliflozin was able to convert early and sustained reduction in the risk of CVD death versus the placebo. Not only the glycemic control people were able to achieve in the trial, we could also see that there was reduction in the systolic blood pressure with this molecule. Empagliflozin used for 12 weeks improved the odds of achieving the SBP less than 130 by 69%. There was decreased requirement of insulin by the patient, because this is a molecule with a different mechanism of action, can be added with any OAD. Chances of one going for insulin get reduced. So that's one benefit we could get with this molecule. It consistently reduced the risk of CV death in patients with ASCVD and T2DM regardless of CVD manifestation. So whether the patient has got a prior MI, prior heart failure, in fact it is a good molecule for primary prevention as well. So now they talk about adding this molecule in the first go. Why to wait for the risk factor to set in, can be added at the beginning itself. So in the 3 years, what we could have got is that, so there has been, there are certain non-glycemic benefit on the top of the standard of care. 9.8 CV event reduction, 8.5 CKD event prevention. Again, there was reduced incidence of renal failure, hypokalemia, reduced incidence of obstructive sleep apnea, edema, and there much greater reduction in the insulin requirement for these patients. So talking about almost all the guidelines, they talk about this molecule, and it has become the choice all across the globe now. And ADA, RSSDI that we prefer, they talk about adding this molecule in the beginning, at least for those who have ASCVD, cardio-renal risk factors. Talking about the efficacy, we know there's a reduction of around 1.5% depending upon the baseline A1C. Higher the A1C, higher the reduction in the HbA1c we could get. And combining the two molecules is always the standard of care the ADA talk about. We don't have to go step by step, adding one molecule, then second and the third. Now they talk about complementary mechanism of action, and now the companies are coming up with the multiple combinations of empagliflozin, whether it is DPP-4 inhibitor or the metformin. So if baseline A1C is more than 10% or maybe 9%, better to add the multiple molecules with different mechanism of action where we could achieve greater reduction in A1C in a smaller duration of time, because we want to give the effect of metabolic memory to our patients, where we want early achievement of A1C by giving the fixed dose combination, because the fixed dose combination did not only reduce the pill burden, they reduce the cost of the therapy and improve the compliance as well. So empagliflozin as an add-on to metformin can further reduce the A1C, body weight and SBP in people. That has been well proven. And of course, we know the sulfonylurea causes the weight gain, and with the empagliflozin we will have the weight loss. So there are good number of effects if we compare between the sulfonylurea molecule and the empagliflozin. Talking about the combination, AMPA versus CETA, DAPA versus CETA. So these are the studies which are showing that AMPA, the efficacy is better versus the DAPA. So there are some studies which, DAPA people come up with their studies, AMPA people will come up with their studies. I think with initially we had the, hurdle of adding empagliflozin just because of the cost. Now the patent has been off and studies a little more in favor of the empagliflozin, whether it is in terms of the efficacy for the diabetes control or the cardiovascular, the renal benefit. So now the price has gone down, so we can choose very well EMPA for all majority of our patients, and we should give combination molecules rather than each molecule alone. So this was all about today's discussion about the empagliflozin. Thank you everyone.
So thank you, Dr. Viveka, for joining us. So friends, you have gone through a very wonderful lecture by Dr. Bhavna, elucidating the effects and the benefits of initiating SGLT2 inhibitors at the very outset, considering the benefits that it accrues. Also, we are looking at effect on immunity, the liver profile, neurological benefits, neuromuscular benefits, etc. So there is a whole lot of spectrum where work is being done, and they are almost miracle molecules of this particular decade. If you go back in time, you thought that how a molecule which was addressing the pathology of a disease could be so beneficial, but over a period of time they stood the test of time and been proven to be extremely, extremely beneficial. So before I set the ball rolling,
I would just interrupt Dr. Sengupta. We have to felicitate Dr. Anil Sharma sir. We were to felicitate him before the presentation. I would request Dr. S Sengupta and Dr. Lamparasha to please come here. We would like to welcome you to the forum, sir. Dr. S. Podar and Dr. Lamparasha, please. Let's hear it for Dr. Kumar. I would request Dr. Lamparasha to hand over a cup of Physicians Forum of India to Dr. Anil sir. Sir, I just want you to read the motto of the forum, sir. Dr. Anil sir, you are here for the first time, sir.
Okay. It's empowering doctors for a healthy India. I'm really humbled and surprised and humbled by this felicitation. I actually had to talk something with Dr. Chauhan for something. Thank you very much. And I wish I can join this group and as much as possible.
You are welcome.
Thank you very much.
You're welcome. Thank you, sir. Please take your seat and we will discuss. We will do what you came for, sir. I give it to Dr. Sengupta. I want you to understand one thing. You remember Dr. Bhavna Atri was sick when she came to give a presentation in Hotel Surya. She said I would go at 9, exactly at 10 o'clock, and she stayed till quarter to 12, 11:45. Now today she is fine, but she says kindly spare me. I have been answering all the questions you have ever asked me, even when I was 104 febrile. So I think today we should celebrate her being afebrile. Okay, so not by 1 o'clock. Everyone to ask only one question, and I would give it to Dr. Sengupta to start the ball rolling.
so Dr. Bhavna is very, she has said that she will be over in 10 minutes. So just to set the ball rolling before I go on to the August gathering, in pre-diabetes, do you recommend the initiation? I mean, I'm not talking about the 5.7, 5.8 tests, but 6.3, 6.4-ish. And if the patient has a strong background, family history of diabetes and other cardiometabolic conditions, would you, I mean, off-label, if not otherwise, initiate SGLT2 and the DPP4 inhibitors or along with the lifestyle modification? Your take on that?
So, for a pre-diabetic patient, if has a very strong family history of ASCVD and all those risk factors, patient has got dyslipidemia, or the patient is obese, or patient is hypertensive, if carrying these risk factors, better to start SGLT2 inhibitor, I feel, because we are talking about the effect of SGLT2 inhibitor on the cardiorenal parameters, which would be there. We know that pre-diabetic patients are equally at risk for cardiorenal complication as the diabetic patient. So we can consider adding this molecule, which may help in some weight loss, SBP reduction, lipid. So we can consider. It's an off-label use. People can choose.
So over to the forum for.
Dr. Bhavna, thank you very much for agreeing to do this. I know Sindhu was looking for an endocrinologist. We spoke to many people, and then she gave me the good news. Dr. Bhavna has agreed, and I knew that you would agree. Thank you so much for coming to the forum as often as you do, and please keep coming more often. I promise Dr. Tulsi will ask you fewer questions. The more you come, fewer the questions and simpler the questions. Okay, I have a very simple question to answer. You please answer it in as much brevity, as much context as you can.
10 minutes is given all of us. So.
Yeah, 1 minute, sir. Please give me Babu Moshai.
Your time starts now.
Babu Moshai.
Babu Moshai.
After UKPDS, we knew that the microvascular complications were very well targeted by whatever therapy we did, whether it was neuropathy, whether it was retinopathy, or it was nephropathy. But there was nothing to celebrate on front of the macrovascular issues. For the first time after Empagliflozin, we came to know of a drug which was bridging the micro and the macrovascular divide. In your considered opinion now, after the patent is off on Empagliflozin, what are the contributors which have led to such remarkable success of SGLT2 inhibitors, especially Empagliflozin? Part 1. Part 2. Subsequent and even preceding to Empagliflozin, there was Empagliflozin. Almost simultaneously, there was Dapagliflozin. With Empagliflozin trial, we found that MACE was reduced. Even in canvas, the MACE was reduced. And even with DAPA, MACE, there was no reduction in MACE. But there was but very little reduction.
Just a comment. So the subset of the DAPA patients in all the trials who had atherosclerotic cardiovascular disease, the effects were almost absolutely similar to Empagliflozin, the subset. The trials when we were looking at, because it was more of a real world scenario which was taken into consideration, so the overall results were different, and I would ask her to bear me on this. But the subset of patients who had established ASCVD, the effects were almost absolutely similar to what we had seen with Empagliflozin. Heart failure, etc. Obviously, you had results which defined DAPA more than this, but the overall scenario was this.
I have not completed the second part. And good introduction, the real world study of DAPA and everything. Despite MACE being reduced with Cana, and whatever Dr. Sengupta is saying, the MACE is getting reduced in the real world studies with DAPA, the overall mortality and cardiovascular mortality was not impacted significantly even in Cmes. Empagliflozin, of course, we don't hear about now any longer, and Dapagliflozin also made an entry, I would say a backgate entry, through DAPA-CKD and DAPA-HF. I want to know from you, with your experience, what has led to this remarkable success of Empagliflozin on bridging the gap between micro and the macrovascular front?
So yes, UKPDS, the landmark trial, which informed us that with good glycemic control, taking care of all the parameters like blood pressure, lipids, along with the glucose control, we can get improvement in the microvascular complication. But there was a later on the follow-up of UKPDS, and they found that even the microvascular complication was improved, not just micro with UKPDS. So overall, when we improve the glucose control, when we look after other parameters, there is improvement in both the fronts. So why EMPA made this remarkable journey? I would say one, because of the trials, and secondly, because of the trials, the early acceptability by the people and the results. The studies are very important part for us when they were conducted, and number of studies consecutively, one by one, they were coming. So this was a molecule which has shown us that it is not even providing the safety. It's not just safe; it is protecting. If you look at the baseline characters of Canvas trial, the trial for the DAPA and the EMPA, the Empagliflozin, the EMPA-REG outcome, the majority of the people has got a huge ASCVD burden. So the baseline characters of these three trials were drastically they were different, and that is why we could see benefit in all the fronts for the Empagliflozin and not so for the DAPA and the Canagliflozin. For the DAPA trial, there was only a small proportion of people who had ASCVD or the ASCVD risk factor. They were a huge population that called for the primary prevention, and therefore we could not get that significant reduction in the cardiovascular mortality and the heart failure hospitalization with dapagliflozin. So in my opinion, when the Cana came, there were one or two issues with the Cana, like the issues of the gangrene, and the diabetic foot, that halted. And then the EMPA came to the market and the pharmacotherapy with the trials. So it was, I would say it's a class effect. Second, the pharmaco company, when they had these one by one trial and the kind of the baseline characteristics that they came with, that also affect our choice. Last few years, I was using more DEPA over the EMPA, I would say, because of the cost issue. And DEPA has also the kidney trial and the heart failure trial, we are getting the good results there also. So I think for us not to compare these trials and decide which one is better than what, I think between the DAPA and EMPA we can choose these molecules, and we can have our own experience because we don't have head-to-head trial to compare between these molecules.
Absolutely spot on. With EMPA, it was the first drug which showed mortality benefit, which was a huge blockbuster kind of a thing. And then when it was presented at the ESD for the first time, there was a standing ovation for almost 10 minutes continuous, because this was something which was never expected or seen before. And like we were discussing, these small subset of patients, even with DAPA, with established ASCVD had almost similar benefit, but since the DAPA trials had a larger real-world scenario of patients, the statistical benefits were not to that extent as was shown in this. Obviously, if you have a patient with an established huge ASCVD risk and burden, it's something like if you have a patient with an A1C of 11%, and if you try to reduce, he comes down better and faster to maybe around 8%. And if you have a patient with 8% A1C, if you try to coming down to 6.5 or 7 is, that much more difficult. You have to basically look at it from that perspective also. But no denial of the fact that the SGLT2 molecule, the entire spectrum has really revolutionized therapy of diabetology the world over.
Ma'am, my second question, and I'll go to the champions. Yeah, I'm coming to the notice. Yeah, no, sir, no. Kuch aisa na karo, sir. You are also second Babu Moshai. Babu Moshai too.
No.
Yeah, he knows more Bengali than you. Dr. Bhavna ma'am, what is so specific about the SGLT2 inhibitors? We know they are getting the entire thing is taking place in proximal coronary tubule part 1, SGLT1, SGLT2 inhibitors. What are they doing to the kidney that they slow down the decline in kidney function and they are able to maintain EGFR? As actually we know, DAPA-CKD came after credence, even much before EMPA kidney. And it was prematurely terminated because there was such a wonderful effect. What is that effect which is maintaining the kidney function. Can you explain it to us?
So SGLT2 inhibitor, what they do is there is the vasoconstriction at the level of upper tetradiol, as a result of which the glomerular filtration gets reduced. So if you talk about the diabetic nephropathy, what happens in the diabetic nephropathy, initially the first step is the hyperfiltration happening at the level of glomerulus, which then drive the process of leakage of protein. Second thing, at each organ, there is the inflammation which is happening. The plaque is settled in the vessels. The pro-inflammatory molecules, they are on rise. The anti-inflammatory, they get reduced. So it has effect direct on the level of kidney by reducing the hyperfiltration at the level of kidney, reducing the tubular destruction. And secondly, at the level of cells, by reducing the inflammation, it reduces the ASCVD burden. Apart from the glycemic improvement, apart from the blood pressure, apart from the weight loss, and apart from the dyslipidemia improvement. So that is why this molecule has got different mechanism apart from the other molecules.
Wonderful. Dr. Tulsi sir.
Thank you, Dr. Chauhan, for those wonderful questions you asked. I think you must have asked about 10 questions. Anyway, let me proceed. I'll ask just 3 questions. Dr. Chauhan is counting. So, one would be regarding the pro-calcific effects of statins. I am referring to the plaque paradox. Dr. Bhavna, the plaque paradox.
Mike.
So, what happens at the level of plaque? The plaque basically carries one LDL molecule, bad adipocytes. There are cells which produce lot amount of collagen and then fibrosis is happening. So, statins, what they are doing is, they are reducing this accumulation of especially the small oxidized LDL molecules at the level of the plaque, and along with that they basically prevent the rupture of plaques which happen, and therefore we get the dual benefit. One is the reduction LDL that we see. Second, the stabilization of the plaque where we prevent the acute rupture which is the cause of mortality in majority of the patients.
So friends, Dr. Bhavna said that statins reduce it increases calcification to stabilize the plaque, at the same time reduces the lipid-rich core of the plaque. So it stabilizes the plaque. Do we have this feature in even PCSK9 inhibitors? Do they increase calcifications?
We don't have this effect with the PCSK9. We don't have data for that as of now. But LDL numbers, the value of LDL is significantly correlated with the burden of ASCVD. If something is reducing LDL by around 50 to 60%, we get a significant reduction in the ASCVD. So this is what matters to us.
Right. So my last 2 questions would be regarding the CIAKI, contrast-induced AKIs. A recent study published said this EMPA reduces this contrast-induced AKIs. Tell us about that.
Sir, I would not suggest any use of this molecule as of now for this. What we know is that before any surgery, before any intervention, SGLT2 inhibitors should be stopped, preferably 72 hours or at least 2 days prior. Why we say that? Because we don't want the prerenal AKI to precipitate, we don't want hyperkalemia to precipitate. So we want the stoppage of the molecules prior to the procedure. So as of now, we will not go for the small studies to follow.
So here they are talking about improvements, in contrast-induced AKIs by giving EMPA. Anyway, let me talk to you about the long QT3. See, this is a very lethal arrhythmia, as we know, as compared to the LQT1 and LQT2, because the single episode of LQT3 can be very lethal. And drugs like beta blockers, which are, prescribed and drug of choice in LQT1 and 2, are not effective here. EMPA is effective here. It reduces the sodium current. Talk about this LQT3.
Again, sir, I think you can give the better answer for this.
Thank you, sir. Thank you, ma'am.
Wonderful answering, Dr. Bhavna. Yeah, coming to you, sir. Coming to you. Sir, instant peripheral expression से आरोप सर जी. Dr. ML Tata sir.
ना मुस्कुराओ तो कोई बात नहीं. Sir, my last and the initial questions 1 and 2. 1 to Dr. Sengupta. Sir, आपने कहा था प्री सर सवाल तो पूछ लेते. मैंने ये कहा था कि आपने
मेरे को जब ल्यूपिन ऑनरेडियम देगी मैं आंसर
आपने सवाल पूछा था प्री डायबिटिक पे. तो प्री डायबिटिक ओबीज और नॉन ओबीज मैं तो आपसे इसलिए पूछ रहा हूँ जो want to say obese and non-obese will they differ because pre-diabetic obese will differ if a pre-diabetic non-obese. Anyway, so my next question to Dr. Bhavna, heart failure we say quantify with anti-pro-BNP or pro-BNP. So does it matter before we start the medicines whether they were having anti-pro-BNP to this level or beyond that level, will it be more effective or less effective? Does it matter?
SGLT2 inhibitor or the dose of SGLT2 inhibitors?
No, sir is asking, we say that all the SGLT2 inhibitors in the class effect, they benefit heart failure.
Yes.
Sir is asking, is there a standardized anti-pro-BNP levels that we do for each and every patient? Or we say, no, the hospitalization because of heart failure was less, cardiac mortality was less, therefore class effect, HHF is less. So sir is asking that question. Or you have a subset कि इतने प्रो बीएनपी के ऊपर बहुत फायदा है और इतने प्रो बीएनपी के नीचे फायदा नहीं है.
So it's a class effect first of all.
Yellow line, yellow poverty line का एक होता है जो उनको बेनिफिट मिलेगा इनको नहीं मिलेगा.
Sir, I think in terms of heart failure, we have a good number of subsets, whether it is reduced or preserved ejection fraction, the molecule does provide the benefit. But of course, if the pro-BNP levels are higher, say more to 300, then the effects that we see are much greater. But I would say I've seen people, diabetic patients, telling me I'm having dyspnea. Everything is good, my core is fine, but I'm having dyspnea. Get a pro-BNP done, then add a SGLT2 inhibitor, some diuretic. After a week, we will find significant benefit in condition. So I would not say that you need to have a pro-BNP to justify its use, but I think the diabetic patients, any of the cardiac issues, it's important to add this molecule.
Dr. Jitendra Saxena.